Great, thanks so much. Good afternoon, everyone. For folks who don't know me, I'm Allison Kretzinger. I'm our Director of Public Affairs here at the Department of Children, Youth, and Families, joined by Assistant Secretary Natalie Green of Child Welfare Field Options and Interim Assistant Secretary Dr. Vicki Ybarra of the Partnership Prevention and Client Services Division. I'm excited to have this dialogue with you all today. A couple of housekeeping things, and then we'll dive in. We're in a Zoom webinar format, which means there's a question and answer function. It's a Q&A at the bottom of your screen. You can use that to type questions in. We will answer them as we go. Some will answer live with a verbal answer. Some we may answer live by typing it in. And if we don't know the answer or it's a statement for follow-up, we'll capture that in the feedback and follow-up FAQ. So just a few logistics there. This is being recorded. It will be recorded, sent around, and posted on our website. You can go ahead and go to the next slide, give a little context around what we're hoping to accomplish today and why we've pulled this together. I think as many of you all know in the field doing this important work every day, we began implementing 1227, the Keeping Families Together Act, about 3 months ago. And I think there's a lot of wonders, a lot of questions, a lot of opportunities to reflect on implementation as we go, both internally and externally. And so as we have been sort of living into the new legal reality, the new landscape with 1227, there have been a lot of conversations around what does it mean? What's happening? What is the data telling us? What are we learning? And so really this today is intended to be the first conversation of likely many over the short and long term as we lean in to this new landscape and this new law and learn what is happening. We have been meeting pretty regularly with agency leadership. I know the RAs have been talking about this, and I imagine many of you are talking about this in your offices on a pretty consistent basis. There is a desire to share data and some reality about what we're seeing in the external world. And so we're getting ready to do that. But we also know it's really important to share that information with our staff and with our staff first. And so this conversation will be repeated for the external world. Sorry, there's a chat coming in that I was reading and I'll respond to in just a second. This information will be repeated to the external world on Monday. And go from there. I want to, there's a question in the chat around the 4 hours notice, and I do apologize for the short notice. That was on me, are getting the links finalized and some language out. Like I noted, this will be recorded and posted. And this is really to present the data and the analysis from the agency's perspective that has been informed by Natalie and her team and all of you, as well as Vicki, before it goes live. So that's really what the goal of today is to share the preliminary data we're seeing, discussing the relationships around the impact of fentanyl and what we're seeing there, as well as talking about sort of some of the next steps we're taking. So that's really the goal today. And thank you all for joining. And we look forward to the conversation. So with that, we can go to the next slide, and I will let my colleagues introduce themselves and we'll go from there.
Okay, I'll start. Good afternoon, everyone. Natalie Green, Assistant Secretary. I just wanted to add one thing to what Allison stated. I want to make sure we understand this is not the avenue to discuss practice or cases. We just want to tell you what we're finding out from the data right now in regards to 1227, especially since it's being recorded and will be available broadly. We want to make sure that we're not talking case-specific things or anything like that. So I just want to put that reminder out there for staff that are on the call. Welcome, and thank you for joining us.
Good afternoon. I'm Vicki Ybarra, as Allison said, Interim Assistant Secretary right now for Partnership Prevention and Services. Glad to be here today.
It's a great flag, Natalie. Thank you for noting that. I would encourage you to use the question and answer to type chat or feedback or things that need further discussion. If you identify yourself in there, the follow-up will be much easier for Natalie and her team, or Vicki or someone from her team to follow up on sort of next steps. So please feel free to use that. If there are, again, like as Natalie noted, this is not sort of a practice conversation and sort of in the nuts and bolts of specifics, but really a preview for internal staff around what will be released publicly next week when it comes to what we're seeing, the context of the law, the data, et cetera. All right, so with that, I think we will go to the next slide and I will turn it over to Natalie.
Once again, thank you, Allison. Once again, welcome everyone. Thank you for joining us. We recognize it was short notice, but we are recording it, and so those that could not join us due to work-related issues can also listen to it later on. So thank you for your patience in that respect. Excuse me. So the Keeping Families Together Act, you know, it passed in 2021, and we were provided 2 years to be able to implement it in the way the legislature intended. And the intent of the legislation was to safely reduce the number of children in care, reduce racial disproportionality, and to support relatives whenever we can as a primary placement resource for children that we end up having to remove from their homes. Next slide. What the act did was it actually changed the legal standards to remove a child through hospital, not only for us, but for law enforcement and pickup orders. Requires that we place with relatives, and it required that we be able to issue initial licenses to relative that we place with. And as you know, that started October 1st for all relatives that we work in. Next slide. So previously, when we were looking at removal, we looked at the likelihood of future maltreatment around risk, harmful results over time, and we looked at serious threat of substantial harm that included high-risk situations where there was a likelihood of ongoing harm in the future or over time. Currently, we're looking at present or imminent danger to children, physical harm in the near future, and now we're looking at the statute regards to imminent physical harm, which can be interpreted narrowly depending on the circumstances and the situation that you find the child in. Next slide. So what we did was we started with conversations with stakeholders in January 2022 to talk to them about strategies and recommendations, how they thought would be helpful and beneficial to implement 1227. We launched our Foundations of Practice. We started with supervisors at the end of the year. We wanted to make sure that supervisors are well equipped with the information and what the legislature required regarding around 1227, so that they can then in turn turn around and support their staff as they're learning this new way. You all know it's a shift for social workers from risk to imminent physical harm. And so it was a big shift for social workers. We wanted to make sure that we provided all the opportunities we could for them to understand and ask questions. And in March, we launched many of our official trainings. We talked about the dependence petition, the changes that were needed to be able to articulate what we needed to articulate to the courts to be able to get children removed safely. And then we also started safe child consultations on many of the cases that we were planning to have concerns around child safety and safety planning. And of course, it went into effect July 1. And what we're currently doing now, we're monitoring around quality assurance, we're monitoring safe child staffings, and we're looking at data to see what the data is telling us regards to what this legislature has actually done in regards to our practice and impacted children and families. Next slide. The biggest change I think we made was requiring the safe child consultation on all cases except for the ones like tribal cases or the ones that have been staffed somewhere else in the same manner. So once the social worker goes out and determines there's a safety concern and they could not do a safety plan with the family, they will come back and staff this case to see if there's any other ideas, or as our biases coming into play, what else have we missed? What else can we do to be able to not remove this child from this home? And if we still at that point cannot come up with any ideas, then we will take it to the family team decision-making meeting where we would include the family and any other providers they're working with, or whoever else they feel, family members, whoever can come in and maybe help us come up with a safety plan that will stop us from having to remove this child. And if we can't get to that point, then that's when we will file the petition and take the case to shelter care. Next slide. To what we're seeing, I turn it over to Vicki.
You're muted, Vicki.
Having trouble with my pointers. Apologies for that. Thanks, Natalie, for that great introduction. So I'll turn to the data and what we're seeing from the data as a result of the changes in practice and law that Natalie described. It appears as though the law is having the intended effect of reducing removals. We've seen a substantial reduction in the number of children entering care statewide, particularly in some jurisdictions. Many of the children who aren't being placed still have high risk factors, so still show up as moderate, high, and high risk, but aren't meeting the imminent risk of harm standard. So many of those children are remaining with their families in their communities. Initial case reviews of the Safe Child consultations indicate that they are operating as intended, that staff and the department is taking the additional steps necessary to prevent removal of a child and to support safety plans. There are multiple changes happening at one time. We've concentrated on 1227 here and those statutory and practice changes. At the same time, plan of safe care changes have been put into effect, also planned over a period of time, also responsive to legislation that have reduced the screened intakes involving substance exposed newborns. So we think that's also contributing to some of what we're seeing. Washington State for many years has had a high rate of placement. Infants have taken up a large portion of those children who are placed. So when we provide additional pathways, alternative pathways for substance exposed infants, that does reduce the number of children coming into care independent of 1227. At the same time, many of us know that across our state, across the nation, there's a fentanyl crisis that leaves many children at risk. That's happening at the same time, and we're seeing effects unrelated to 1227, but effects on child safety at the same time. And then, of course, what many of us experience is a lack of needed substance use disorder treatment in local communities, and we think that lack of treatment places children at further risk. Next slide, please. I mentioned fentanyl. As you all know, I don't need to tell many of you how dangerous this drug is. We've certainly seen drug and alcohol and substance use exposure has been an issue among child welfare involved families for many years. It's been previous waves of drugs. Fentanyl is different in that it's very dangerous. There's often not a second chance, as you know, when adults or children are ingesting fentanyl. It's being marketed to, in many cases, to be attractive to children. And in many cases, families are not aware that fentanyl is what they're consuming. They may be thinking they're taking another drug, and fentanyl has been laced in enough to be deadly or very dangerous to the adult or the child. So this is happening at the same time that we're implementing 1227 and the plan of safe care. Next slide. Previous to 1227, starting in fiscal 18, since DCYF has been an agency, Washington had already seen over a 35% decrease in the number of children in out-of-home care. And that trend was consistent with national trends for children, but it pre-existed our implementation of 1227. 1227 was layered on top of an already decreasing trend. Since 2020, we've seen an increasing percentage of moderately high and high risk cases being re-referred to CPS intake. So this seems to be the parallel trend that we see. As the number of children placed goes down, the number of children who are rated high or moderately high on the SDM who aren't placed come back into CPS intake and screen in. They tend to cycle in, as might be expected, right? These are children who aren't being placed, but are still in high-risk situations. They continue to come in. So those are trends that existed before 1227. The other trend, as we've noted, is since 19, opioid-related emergencies have dramatically increased across Washington State, both overdoses and other emergencies in both children and adults across the state. Next slide. So in terms of what we've seen since 1227, just looking at the first 3 months of implementation, July through the end of September, compared to July to the end of September in 2022, because there's seasonality, seasonal variation to entries into care, it's most appropriate to look not at the previous months, but rather last year at the same time. We've seen statewide about a 25% decrease in the number of children entering care. And you see here the regional variation. The largest impacts have been in Region 2 and Yakima County, 55% reduction, and Region 5, Pierce County, 43% reduction. Although Yakima County Region 2 have the greatest percent reduction, the actual greatest number reduction is in Pierce County because it's a much more populous county. Next slide. Entries into care are down across all categories, and participation in FVS has been increasing. It hasn't been increasing as much as the number of children entering care has decreased, but FVS is increasing. Again, looking at those first 3 months, July through September of 2022 compared with 2023, the number of voluntary placements has gone down, the number of protective custodies has gone down, and the number of court-approved placements has gone down, while the number of children and cases in family voluntary services has gone up a bit. Next slide. We can look at we can dig into the demographic characteristics, some of the demographic characteristics of families who are being placed now compared to those who were being placed before in the same period last year. Again, just using those first 3 months, July, August, September, we see that the greatest reductions in children entering care are in that 0 to 1 age group. 40% of the statewide reduction is in that age group compared to only 9% for ages 2 to 3, 18% for ages 4 to 11, and about 25% for ages 12 to 17. Again, Washington State has historically had a very high portion of the number of children who enter care who are in that 0 to 1 age group. I think the last couple of years that I've checked our comparisons to national, we've been the 3rd or 4th highest state in the nation in terms of the percent of children entering care who are 0 to 1. And so with the plan of safe care changes especially, it's not surprising that this group has been disproportionately impacted. Next slide. So what were the plan of safe care changes? These two laws and these two pieces of practice, keeping families together, keeping families together and plan of safe care, they're overlapping to prevent removals among substance-affected newborns, substance-exposed infants. Plan of safe care changes are being driven by federal legislation enacted in 2016. That resulted in 2017 with DCYF starting to work with partners and other agencies to plan for what those changes might be. And then starting August 1st of 2023, there is a new pathway for birthing hospitals to take if there is a substance-exposed infant, but there is not a concern about child safety. Of course, healthcare professionals are mandated reporters, but they no longer are required to report every substance-exposed newborn if there is not a concern about child safety. And then we've developed new community resources working with community partners so that there is a place for them to refer the family to get community-based resources if those seem appropriate to the referent. And the Plan of Safe Care website's been recently updated with some of this information. So if you're interested, you can take a look at that resource as well. Next slide. This is just the detail of the numbers that have been decreasing in terms of substance-exposed infants. Historically, they've often been screened in as risk-only intakes, precipitating a CPS response. With the new changes, we likely will see a continued reduction of infants screened in for substance exposure. Here we see a comparison from 2018 to 2023 for the 4 months, May, June, July, and August. Again, there's seasonality to these things. But if you look at 2023, especially the most recent months, you can see that there clearly is a decrease in the number of infants who are being screened in for substance exposure compared to previous years. Next slide. And just as fewer are screened in, fewer are being placed in out-of-home care. So screening comes first, CPS investigation, and then potential placement. Here we see the trend, same kind of trend, same 4 months of each year, 2018 to 2023. May, June, July, August. If you look at the far right, you can clearly see, looks like this goes just through July for placements, but you can clearly see that in July of 2023, there were only 19 substance exposed infants placed in out-of-home care compared to 35 in 2022. So these numbers are in fact going down. Next slide.
Vicky, there's a question in the chat or the Q&A that I think we should answer before we dive into the fentanyl and critical incident piece. There's a participant asking, can you provide an example of a scenario on what a substance exposed infant without a safety concern would look like? And I don't know, Vicky, if you want to answer that, or Natalie have an idea.
Sure, I'd be happy to take a shot. I have talked with Alyssa about this. So Alyssa Copeland is the program manager for Plan of Safe Care. It might look like a mother on medication-assisted treatment. Perhaps she's on methadone. Her care provider knew she was on methadone throughout her pregnancy. She is stable in treatment. The child is considered substance exposed because the newborn will have methadone in his or her system, but there is no safety concern. Hope that helps. Natalie, are there other types of situations that you might think of?
It could be a parent, a mother that's recently in treatment, decided to participate in treatment, actively doing services, but the child still is born, impacted.
Thanks. All right. So I mentioned fentanyl a couple of times. We want to be transparent that there are other trends happening unrelated to 1227. Some of you may have recently seen that the Office of Family and Child Ombuds released their annual report on critical incidents, child deaths, and near deaths that the agency is required to review. And we have seen an increase in critical incidents involving young children, especially in Washington, related to fentanyl. Next slide. Sorry, we know that there have not been the additional investment with 1227. There's not been the additional investment on the part of the state or communities in substance use disorder and other services that our families need. There aren't a new plethora of SUD treatment beds to allow families to stay together. We know that mental health and other services are often not available. There were COVID-related stimulus funds available to support families in poverty. We know that had a positive impact. It did reduce the number of children coming into child welfare across the nation, and those federal supports have ended. And then, of course, housing remains a challenge for many of our families. So although the legislation went in place for us to reduce the number of children entering care, we did not see a similar increase in some of these community-based supports that we know families need. So we know that at-risk families still have a great need for these kinds of services and others. Next slide. Back to fentanyl. This is a trend on the fentanyl-related critical incidents that are increasing among children in Washington. The department is required to review critical incidents that happen in children, fatalities and near fatalities, if it is within 12 months of child welfare involvement. So if they were involved with child welfare as long as 12 months ago, and they have an incident, then we are required to review that incident. So these come to our attention, and we have a unit that tracks these. We knew that in 2022, the number had gone up to 41 from a previous year of 27. So last year, this was a concern. OFCO did their annual report. It was a concern. The agency did our reviews. It was a concern. This year, we project that we will see even more of these. We're projecting 48 at the current rate of acceptance. The orange line there are those that we're projecting, additional that we're projecting. So we expect to see even more, and more of these are related to fentanyl. Next slide. This is a look at that fentanyl comparison. So on the left, we see the age group of children that require case review, critical incidents that require case review. And we could see that the vast majority for the last couple of years, and in fact, in past years, have been clumped on that far left end. So 0 to 3 is a big population that we review and are involved in critical incidents. On the right, what you see is of those 32 critical incidents, 32 last year and 32 this year through August that involved children 0 to 3, what portion and how many involved fentanyl. As you can see, in 2022, it was about half, and this year it's about more than 3/4. These are often accidental ingestions of fentanyl on the part of young children. So young children in their own homes who are being exposed to fentanyl accidentally, and who often die, because with fentanyl, there really isn't a second chance unless there is treatment readily available to reverse the effects. Next slide. The vast majority of the critical incidents, so child fatalities, near fatalities, are cases in which there was no indicated safety threat at the time of the assessment. So remember, these are cases that the department has been involved with for the last 12 months. So we can look at the assessment data. There was no, in the vast majority of cases, there was no indicated safety threat. But, next slide, most were moderately high or high risk on the SDM. So although this increase is separate from 1227 and was happening before 1227, we're seeing sort of the same pattern of we don't have immediate safety threats, but they are moderately high or high risk. With that, Allison, I'm sorry, I haven't been following the Q&A. If there are questions, I'm happy to answer them. Otherwise, I'll turn it over to you.
Yeah, we're gonna do questions. There's some questions in the chat that I think are yours to take, Vicki. There's 2 that are related, so I'll read them both out if you want to respond to them. I'm confused about the statement that the increase in critical incidences being unrelated to 1227. Can this be clarified? And then the second one is, why are we saying these 2 are unrelated? The 2 being implementation of 1227 and increase of fentanyl related critical incidences. At least they seem correlated. So we'll start there. There's a couple more.
Yeah, I can certainly understand why the questioner would think they're correlated. They're happening at the same time. But go back to slide, I think it's 20, the one with the trend. That one. This is only through August of 2023. So we cannot attribute this trend to 1227. 1227 was implemented July 1st, 2023, and this slide is only through August 24th, 2023. So the projection here is the rate, so those additional 16 are only the rate at which we'd been receiving them through August. So although the increase is happening at the same time, this trend was happening prior to the July 1st, 2023 implementation of 1227. They are happening at the same time. They are both very concerning. Agreed.
And there's a comment, just I'll note out loud that we know 1227 was implemented early in many counties. I would venture to make the statement, and Vicki, you can correct me, hard to know if that's related or not at this point, given what we know. Mm-hmm. A couple more questions and then some statements that I want to make sure we also note. Are we tracking any fentanyl related critical incidences in placements?
Yes. There are a small number of these that happen in placements. I don't have that division with me, but I have seen a previous chart that we're not using today that split out of home and in-home. Most of these are in-home. There are a very small number, but there's not the same trend of increase. They're just the occasional that happen every year.
Great. Thanks, Vicky. A couple of statements to read out loud that I'll read, and then if Vicky or Natalie have response to, I certainly have response and feeling about some mostly large sediments of agreement here. But the first, we have 6 month, and I'm assuming the word wait needs to be in there, but we have a 6 month wait or 6 month something for PPW beds for mothers with SUD needs, but no SUD treatment beds for fathers, and very few safe and sober homes for fathers who care for infants and children. We agree, Tammy. Thank you for noting that. As soon as we wrap up questions, I'm going to talk about what we're seeing and then what we're asking for as an agency. We see that and know that and have heard that loud and clear and could not agree more. Is there any assessment or correlation with the reduced infant placements and the high fatality or near fatality of the 0 to 3 age group?
That correlation can't be drawn yet because it's so new. The plan of safe care changes went into effect August 1st. And as you see here from this slide, this trend on young children has happened, since the last 2 years, since at least 2021, if not before. So it's hard to draw those conclusions. As we get more data, OIAA is committed to continuing to look at possible reasons and possible relationships, but I think it's just too early to know for sure.
There is a comment in the chat as well. It's worrisome that our rate of placement for our most vulnerable children, infants, is going down, while critical incidence for children affected by fentanyl is going up. The safety threat is that parents are using fentanyl. You cannot safely plan around fentanyl. A lockbox does not keep infants safe from fentanyl. I don't know, Vicky or Natalie, if you want to respond to that sentiment.
I think you safety plan the same way you would safety plan on any meth or heroin or any other drug. If you feel that you cannot safety plan around it, then we take action that we would normally take, which is we would look for removal. And so, really you need parents to wash their hands, you need them to change their clothes. But you would safety plan the same way you would approach it the same way you would approach any drug situation. Can or cannot not ensure the child's safety, and if you cannot, due to whatever that circumstance may be, then we would need to staff that for filing or out of home. Because all safety plans are dependent on parents' willingness to be cooperative on those plans, and so we just make those decisions based on what we find in that moment in time.
Thanks, Natalie. Allison, if there are no more questions, I think the next section is yours.
Yes, thank you so much. Thanks, Vicky and Natalie. We can, Chelsea, move towards what are we doing and where are we going? So what are we doing? We're continuing to monitor the data. As Vicky noted, it's very early in implementation. It's too early to draw conclusion or causation, but we continue to monitor the data. And we're conducting deep qualitative reviews, case studies on what we're seeing, especially in regions 2 and 5. I have to do the math every time I do it. That's what those fingers were. We'll explore adjustments to practice if needed, if things emerge. We are absolutely informing the legislature and our advocacy partners, our allies, of resources needed for SUD treatment and community-based services. We are bringing on SUD professionals. 12 of them will be brought on to support in the field. And I'll just note a comment earlier about our SUD program manager, Jimmy's availability to be a resource as well. And we're also looking at this concept of exploring third-party participants for safety plans. Some families have natural supports, natural networks that can be part of their safety plan, and some families don't. And so we're looking at this, exploring the concept of, is there a way to put natural supports or quasi-natural supports in that can help be part of a safety plan to ensure the safety and prevent that out-of-home removal.
Allison, can I answer a question?
Yeah.
It's in the chat. So we're leaving infants and toddlers in homes where parents actively use fentanyl, just asking them to agree to wash their hands or clothes. I'm sure that's not what I meant. That's not what I said. I said those are some of the things that parents will need to be willing to do. I didn't say that would be your safety planning. And so once again, in fentanyl, you plan based on the circumstances that you find. If you cannot safety plan around it, then you need to do what we would normally do when we cannot safety plan around a child's safety. You just have to make those decisions in the moment when you're working with that family.
Thanks, Natalie. Go ahead and go to the next slide.
I think there were 3 hands that were up, and I want to make sure we don't miss those questions.
Yes, that is correct. I
Unless you just was going to wait till the end. Okay.
Yeah, I was going to wait till the end to do the off mute questions, Natalie, as we sort of move through. So this is a sort of a more around what we are doing around safety planning, which I think, Natalie, you touched on, and we've talked about. We can go ahead and go to the next slide. So what are we asking for? Where are we going? At this point, it's really clear. And thank you to those of you who contributed in the question and answer that we do not have adequate residential treatment and medically assisted treatment available in our state. And so we continue to ask for, demand, beg the legislature and our partners in the governor's office and other state agencies to identify what the barriers are to accessing more treatment, to stand up more PPI beds, PPW beds, as well as that treatment type where the 2 parents can stay together with the child. We hear that scenario more and more, that a parent doesn't want to leave because they may be the more stable parent, despite they may have an active addiction as well. And so we're working on educating our partners and informing around the urgency to continue to push on more SUD treatment being available across the state. Also working with our partners at DOH and others and internally to stay competitive for our SUD professionals, contemplating concepts of paying their licensing fees or other ways to keep them, recruit them, retain them, so they are a part of our continuum and system. And then, like I noted, detox treatment as well as medically assisted treatment or medication for opioid use disorder are 2 of the other things we continue to ask for. That, I think we can go to the next slide. And I think, so yep, that was the end. So there's a couple questions in the Q&A, and then I know there's some hands raised, and so we'll go through those. There's some comments, and again, I'll read the comments out loud, and Natalie or Becky, if you want to respond. I think there's a lot of frustration around courts and workers not feeling supported by AAGs, as it's difficult to articulate imminent physical harm for a newborn when parents have not parented before. So there's not a lot of pushback around filing. Oh, so there is a lot of pushback. Let me read that correctly. So there is a lot of pushback around filing and or petitions not being granted. I don't know, Natalie, if you want to respond to that. Yes,
it's an ongoing concern that we're hearing around, and that's when you please take it up your chain so that it can come to a higher level so we can have those conversations with the AG if we feel the risk is high enough. We still want to be able to file on children we feel are unsafe, whether or not there's a physical imminent harm. And so we want to make sure that you don't just let that slide. You bring it up your chain so that we can have this conversation at the AGs at the higher level.
Thanks, Natalie. Another comment: every time I go into an office, staff complain about being unable to do anything and appear to be getting complacent about not seeking court structure when it might be necessary because they feel their hands are tied and there are new resources, and parents refuse to participate in the process.
Yes, that's also accurate. We have more parents that says, what are you gonna, you can't do anything. This is not dangerous or something, and so once again, all we could do as social workers is assess what we assess and do the work that we're meant to do, which is we see a child is unsafe and we cannot safely plan around it. We need to make every attempt to file or get that child to a safe situation. And so once again, if you're having struggle at your level, please raise it up through the chain so we can have that conversation at a higher level. And we will take it up with the AGs ourselves. They can even come to my level as well. So we can have those conversations about children that need to be safe and what we need to do. And so please do not just wait and take it. Don't leave a child at risk because you think it's not going to go anywhere. We need to bring it up the chain so we can address it.
Thanks, Natalie. I see a lot of thumbs up floating up the side of the screen there. The intent, next comment, the intent of the bill is to decrease the number of out-of-home placements. Unfortunately, many are using the bill to say we should return children who are already in out-of-home placements. But this is an interesting one. If homes are already deemed unsafe and a safety plan was not able to mitigate the threat, we cannot promote the return of the child to an unsafe environment. If family placements have not been deemed safe, out-of-home placement must remain the best choice for these children until parents can achieve a strong pattern of sobriety. Natalie?
Yes, I can answer that. That's accurate. And many parents' attorneys were pushing when 1227 started to say, the situation is no longer relevant. It doesn't meet the causal effect for out-of-home placement of the imminent danger. So we were going to push for return home. And what we asked the regional administrators to do, assess those cases that are still in shelter care and make sure your worker is able to articulate why the placement needs to continue. And so it's on us to say, hey, this is why it needs to continue, be able to articulate why the danger is still, the risk of the child is still present, and why there's been no changes in the behavior of the parents that would say it's okay for this child to return home. But in some cases, sadly, we're going to end up returning because the situation has changed. And the parents are not willing to do services or whatever. And so it's really up to us to be able to articulate why that out of home needs to continue, because you're absolutely right. Parents attorney they told us in advance that they were going to be pushing for many of these cases to be turned over.
There's a question, will there be an opportunity for line staff to give feedback on the dependency petition and opportunity to edit or change it?
No. Yes, we asked for input, and we did trial and did services. But if you have something major you think will make a big difference, please let us know. I can't say that it'll happen. We always have to staff with the AG first, because we're only allowed to change certain sections, of the petition. But yes, let us know if you feel something is really impacting what we need to do, what we need to happen. We're happy to hear. You can send it to Adrian Franklin, whoever is asking that question.
Thanks, Natalie. There's a question about licensing, initial licenses. That is another part of 1227, the initial license piece. What type of impact has there been on licensing or licensing kinship placements who might not be as removed from substance abuse or removed from the parents, I think is the sentence there, due to the quick time frame of the 90 days are being licensed quickly. So one of the pieces of data that we hope to have, and I think we'll have some preliminary data to send out with this deck when we send it out Monday, is what we're seeing in the initial license and the child specific license for those relative placements, right? For folks coming in, we did initial licenses October 1, as Natalie noted. And then we have the child specific license or a full license that needs to be achieved within 90 days. And so we've been asking to the data team and the licensing team, and we'll be able to give you concrete numbers as that moves. Initial indication in a conversation with Assistant Secretary Ruben Reeves of licensing this morning was we're seeing positive impacts. We're seeing initial licenses being issued. We're issuing child specific licenses. People are moving through that process and is going well. I don't know, Vicki, I saw you come off mute. I don't know, you have more to add there.
Yeah, as of this morning, Ruben said we'd done 43 initial licenses since July 1st. So
That's correct.
Yeah.
Great. Excellent. Okay, I'm going to flip to the hands that are raised. And then we can come back to if there's more questions in the chat. Okay. So the first person I'm going to unmute is Ian Potter. Ian, you should be able to unmute yourself and ask your question. Well, I saw Ian's hand come down, but we can't hear Ian. Maybe Ian doesn't have a question anymore. Ian, if you're talking, we can't hear you. I'm going to move to Sunshine Nelson. If you want to come off mute and ask your question.
So if I raised my hand, I didn't mean to.
Oh,
Hi, Sunshine.
You came off mute. We can hear you.
I just wanted to say hi to Natalie.
Hi, Sunshine.
Excellent. Okay, I will, let's see. Jimmy, I saw your hand come up too. Let me go ahead and Jimmy, if you want to come off mute, go ahead.
Yes, just real quick. I heard someone mention that lockboxes weren't part of safety planning, and that is absolutely correct. Lockboxes are harm reduction kits. They're part of harm reduction, and they are providing the family with useful tools. For instance, it will have a supply of Narcan, which is known as the #1 prevention method to address an overdose incident. Fentanyl test strips, brochures created by parents to help educate parents on the harmful effects of fentanyl use, and other information that is located within the harm reduction kit. So I just wanted to clarify that it is not a safety planning kit, it is a harm reduction kit.
Thank you, Jimmy. That is a good clarification and an important distinction as well. There's a comment in the Q&A that I will also read and couldn't agree more. It often seems that each court-involved situation is very subjective, depending on the social worker, AG, PD, which I think probably means parents' attorney or public defense, and judge commissioner. Lack of consistency is an issue. And Natalie, if you want to chime in there.
All I can say is that's accurate. That's true. Depending on what court system you're in, how the judge interprets 1227 depends on the ruling that you're going to get. So which is kind of unfair, but that is accurate.
Yeah, great question. It is. And the experience in court, we know, is complicates this as well.
Yeah. Yeah.
Next, there's a question about licensing. Are they going to change the licensing process to be able to modify the child-specific license when families are given additional children? This is a growing issue I'm seeing now, that we are licensing child-specific licenses. They are required to go through the entire licensing process for a new license if and when given another child. This is a barrier for families and CPAs who are not wanting to take more placements because there's no easy way to modify the license. That is a great question. Ruben is not here, and I am not, I don't want to get out over my skis. But that is a great question. And I'm assuming the second child would be a child that has a familial or kin-like connection as well. We certainly will loop back on that one and provide some follow-up in the response in the follow-up there as well. Thank you for raising that. Why are the AGs not writing the petitions, and field ops can then write a preliminary report with the supportive evidence to the allegations? We'll let Natalie take that.
You're
No.
on mute, Natalie.
Sorry about that. I'm just saying I don't understand the question. I wonder if whoever asked the question, could they raise their hand so they can maybe add a little bit of information to it.
Yeah, if whoever asked that question wants to come off, raise your hand and we'll move you in to provide some.
I see that it was anonymous, though. They might want to be anonymous. I can try. I mean, the social worker has the information that needs to go into the petition. That's one of the reasons I think that where we had the issue with the court unit as well, because the social worker is now required to testify based on the efforts that they've made. And so they're the ones that hold most of the information. Oh, was that Jeanette? Jeanette
Perfect.
has her hand up.
I am moving you into the, you should be able to come off mute, Jeanette.
Okay, I think I'm off mute.
Was
You're
that
good.
your
We can
question,
hear you.
Jeanette?
Go ahead.
Yeah, that wasn't my question, but I think, oh, can you
Go
hear
ahead.
me?
Yes, I can. Go
Okay.
ahead.
It wasn't my question, but I definitely think it's something that I've heard a lot from workers, is that the new petition takes significantly longer to write. And when you have a child in protective custody and you only have, 72 hours,
Yes.
workers are hitting, if you get a Monday PC, some workers are hitting their 40 hours by Wednesday.
I have heard that.
So I think that's maybe where the question about having AGs or having paralegals or some sort of assistance with writing petitions is coming from.
I gotcha. I have heard that, and I have heard it takes a lot longer. And I heard from the AG side as well that it's taken them a lot longer to actually review those because the petitions are so much longer. So it's something that I am looking into and seeing how we can help that situation. So I have recognized that. Thank you for that additional information.
And I wonder if there's opportunity, I'll just say out loud, Natalie, is the conversations we're having around sort of the preliminary workload data and having that conversation to think about some of those pieces.
I agree.
Thank you, Jeanette. That was helpful context. A couple more comments. There are several commissioners that believe if they rule that the department has not done enough with active or reasonable efforts, that will force the department to provide more resources.
That's true.
I would imagine some commissioners feel that way. And
and they don't care that we don't have services or resources available. They just rule. Yeah.
Right.
Which is unfortunate for workers that have to stand in front of judges and explain. So
are we doing any training with our AAGs around training on House Bill 1227 to reduce these inconsistencies, the subjective interpretation of 1227? Natalie, I don't know if you want to talk a little bit about training with the AGs.
well, it's so new that we're not learning yet that we have different subjectives. So if you have instances where you feel this is happening, it would be great to have those so then we can have a conversation. Because it's always been subjective with the AGs, but we really work together on 1227, so we're hopeful that it's not as inconsistent as a AG review used to be. But if you have some real specific example, please send them to myself, which is Adrian Franklin, and we will connect with the AGs around what we're seeing. Because I do meet with them and I'll say, what are we seeing in 1227? But I'm not hearing inconsistencies from them, but I know you guys will be aware of that. So please send those examples to me and we'll be happy to look into it.
Great, thank you. And there's just a comment: in Oregon, workers write a prelim report and provide evidence to the allegations that the AGs have outlined. So, and food for fodder as we think about impact and potential changes. I don't see any more questions coming in. I will just wrap up by saying thank you again for everyone who joined and owning the very short notice. Apologies. Oh, one more comment. We have an increase of cases remaining in shelter care when children are returned to parents with court structure. These children do not follow policies for in-home dependencies as they are not deemed dependent, and they do not fall under our policies for out-of-home placement. It has made it difficult to gain compliance from the family as there are no policies to address these children. I don't know, Natalie, if you want to respond or if we want to do some follow-up on that.
I'll have to follow up on that. That's interesting.
Okay, Tammy, thank you for the
Thank
note.
you, Tammy.
I'll just note that I really appreciate folks joining on short notice. Like I noted, we will send out this deck. We'll pull in some of the initial and child-specific license information as well. We'll send out the deck and the webinar recording so you can hear the question and answer on that conversation. We'll send that out Monday afternoon. There'll be one deck, 2 recordings because we're doing an external webinar as well. All of that will get posted to our 1227 implementation page. It is a commitment by the agency that will release data. The data you saw today will release quarterly. So we'll update that data quarterly. I know I heard Natalie talk about, elevating issues, reaching out with ideas and questions. I'm sure the same would go through for Vicki and her team as well. I think we are all sort of learning together as we move forward. And that's where we're at, sort of unpacking these pieces. We'll have a conversation with external stakeholders, same format, same information on Monday, and then information will be posted and sent out. So encourage you to reach out. And really just can't thank you all enough for the work you're doing every day, the hard work of the agency and ensuring that kids and families have what they need and are safe. So thank you all for taking time out of your busy days to be here for this conversation and sharing your feedback and sharing your thoughts and sharing your responses. I know this has not been an easy lift. And we're learning a lot as we go.
Yes, thank you all for joining us. I appreciate your hard work. Take care. Bye.
Thanks, everyone.